Nice to see you all today on a Friday morning. If you allow me, I'll take you for a guided tour of the ART Center. The idea of the center was conceived in 2001 by General Mrs. Arora. However, the center came into being in 2003. And this is our team of ART who has put in a lot of hard work to make this workshop a great success. We are looking forward for a great interactive session with you all today. We'll go in for a tour of the center. Here, what we believe in is not just healing the patient, but healing their heart and their mind. Please come. I'll take you for a tour of the center. This is the first ART center which was conceived in the government sector for treating all the patients free. This is our reception area where we have usually our patients waiting for the ultrasounds or other problems. We not only believe in treating the patient but making them pain-free, all the pains, mental, psychological or physical. This is our injection room. We have a dedicated nursing officer who is thoroughly dedicated to giving all the injections to patients. We give injections to almost 200 to 300 patients per day, and this is where the injections are administered to our patients. We now come to our andrology lab, which is being headed by Colonel Prashant. Here we take all the semen samples, analyze them, do all the sperm function tests. We have a workstation here. You can see the centrifuge. We have two consultation rooms, as you can see. We have two ultrasound machines to do all the ultrasounds, as we have almost an OPD to a tune of 250 to 300 per day. We need to have at least two rooms to scan all the patients in the same day. This is our semen collection room. As we go ahead, this is our conference room. Today, of course, it has been turned into an AV room for the conference. This is our IUI room where we carry out our intrauterine insemination. It is also converted into a cold storage room.
Sorry for the interruption, but this is all. Okay, we are back.
Sorry, there was some problem with the video. I hope you can see me again and hear me again. From here we enter into our sterile zone.
All the ultrasounds, live workshop will be here.
This is our post-op detention room where immediately after the procedures like ovum pickup, embryo reduction, we keep our patient for some time. We have two separate changing rooms, one for the doctors and one for the staff.
These are observation and insemination room. This is the room where the doctors normally take a break.
Then comes the
hard day's work,
scrub room.
have a small cup of tea. That's where the OT starts, and the beginning where she's standing right now is where we watch. As we all know, all those who
I'm very sorry, I think I'm not audible to you. Can you hear me now?
you really have to clean yourself, clean your mind, clean your clean your heart. So
And now I will take you to basically the OT, the main OT from where we will be demonstrating you all the procedures like ovum pickup, embryo transfer today. This is our OT, the ultrasound machine and the anesthesia equipment. Inside is our embryology lab and the micro manipulation room. This is basically the embryology lab. You can see it from outside. And this is basically the freezing, where we have all our cryocams stored with. I think that's all from our end at this moment. We'll be seeing you after the breakfast session. Thank you so much.
Hello, good morning everybody. She is 29-year-old, married for 6 years, and she had previous one abortion. Her endocrine profile are within normal limits. Viral markers are not detected. She has bilateral spill on HSG. Her hysteroscopy finding is within normal limits, and laparoscopy could not detect any abnormality, except for she has a little enlarged ovaries.
So I think Vivek will just show you a scan and see what wrong we can pick up on a scan. And
That
then,
is uterus.
Then we can discuss on what we can do or how we can manage such cases. So now we go to the scan. He's got the probe in already, and you can see the uterus.
Yeah, it is. The machine is linked.
Are you seeing both the pictures? Okay, so you have a picture-in-picture. You have Vivek scanning the patient, and you have on the screen. So he will describe what he's seeing, and then we'll come to a diagnosis and then plan what we can do for her.
Hi, thank you, sir. Can you all hear me from this mic?
Yes.
Yes, okay, ma'am. Now, this patient is 29 years old, and she's, somebody told me that she's already got one abortion done. Was it one abortion done?
Yeah.
At how many gestation, please?
6 weeks. Yes.
6 weeks. And then it was cleaned, I mean, a DNC was performed on her?
Yeah.
Okay, and when was the DNC performed?
At the 6 weeks gestation.
No. How many months ago? How many years?
In 2014.
Okay. So, ma'am, here we have a patient which is 29 years old. She's married for 6 years, underwent one abortion, spontaneous abortion, at about gestation of 6 weeks, and she underwent a DNC. This happened in year 2014. Ever since, she's been trying to conceive, and she's come here. So we are doing our TVS here, and we have this beautiful view of the uterus. Here we can see the entire length of the uterus, and what we notice in our first look here is that there are multiple, can you see this images? We can see some few Nabatean follicles in the cervix, this being the cervix, this being the cervico-uteral junction, this being the fundus of the uterus, this is the endometrium. Now in the first look we can measure the endometrium, and let me just measure the endometrium, the thickness of the endometrium at the widest point, and then we'll go on to further things. So endometrium measures around 7 millimeters. But what we notice here is, let's start first with the endometrium. Now the point is that we should spend some time looking at the endometrium, because we may pick up some endometrial peristalsis. Even on day 2 we can see a minimal amount of fluid, which is of course the menstrual flow, which is in the uterine endocavity. This is a thin streak of fluid. If you can see this thin streak of fluid, this is the menstrual flow. But what I want you to see is the endometrial peristalsis. So we are holding forth on the endometrium, waiting for a little bit of peristalsis, because if that happens, then we are reassured that her endometrium peristalsis is normal, so that the sperm migration and the ovum transportation is good. And if the endometrial peristalsis is not seen, then we may have to think other things. Another thing is that once we put on a power Doppler, we must be able to see the tiny spiral arteries in all the zones of endometrium, including the inner zone. Can you see the spiral arteries in the inner zone of endometrium? Which means that her endometrium is very nicely vascularized. Coming back to the endometrium, we are still waiting for the endometrial peristalsis to happen. but anyway, looking at the fundus now, can you pick up this cystic lesion here? This is an irregular cystic lesion sitting on top of the fundal region, and I wonder what this is, because then we need to know this cystic lesion is also avascular. The size of this cystic lesion measures about 7 millimeters in diameter. So it is fairly significant here. Considering that there's a history of infertility, then we must rule out there's another cystic lesion right adjoining to this one. So we are rather concerned about the pathology, if there is any pathology in these cystic areas in the fundus. We can do a 3D sweep also, and we can further delineate the lesions.
See, basically we want to be sure the cystic lesion is not connected to the endometrium. If it is connected to the endometrium, if it is sheets going from the endometrium, then one of the diagnoses could be adenomyosis. I mean, these are endometrial tissues which have gone there and bled, and that black area is the blood, and the white around is, because in the posterior wall also you see a few small black and white areas. And now again, look at the fundus here in the 3D reconstructed, and you probably that the fundus is a little broken there, and the endometrial myometrial junction is probably disturbed. So a diagnosis of adenomyosis or myometrial cyst can be kept in mind as one of the DDs for the cyst, because it's avascular. Had it been vascular, then I would have thought on AV fistulas, because of AV malformations, because of the history of DNCs.
True, right, sir. So in this case, as Dr. Malhotra has rightly pointed out, that this could be one of the reasons for this patient's problem here. I had earlier scanned a beautiful section here, and you could see that there's this cystic lesion. Can you see in this 3D reconstructed view?
See that cyst is lying just over the fundus. It's probably.
It is lying, sitting on top of the fundus, and it's not touching the endometrium. So which means that this could be the pathology here, and we need to work it up further. Both the ostia are fine. The endometrial echoes appear okay. The endometrial myometrial junction is normal. And here we can even change the edit light, and then we can see the junctions very nicely. So we can see that the endometrial myometrial junctions are all proper, and so this is one thing. So we are not overwriting then. From the uterus we go on to the ovaries. In the meantime, it's always a good idea to look for any dilated tubes. How to look for dilated tubes? There will be tubular sausage shaped structures which could be lying medial to the ovaries, and there could be ladies' waist sign, and sometimes the cogwheel that is indicative of the dilated tubes. That is, but then that is all right here. So we are moving on to the ovaries, and what do we see? In the ovaries we see multiple follicles, and they are generally seen almost at the peripheries. So which means that here we are dealing with a case of polycystic ovary where there is a stroma. Now how do we see the echogenicity of the stroma? We compare it with the uterine myometrium, and if the uterine myometrium, generally it should be hypoechoic or isoechoic to the uterus. But here, can you see the whitish areas, ma'am? Can everyone see this whitish area, which means that the stroma is echogenic. It is more echogenic than usual. So we have a bulky ovary, and we have a echogenic stroma, and we have multiple follicles which are arranged in the periphery. So this is giving us a picture of a polycystic ovary. Now we need to know what is the grading of this polycystic ovary, what is the echogenicity, and what is the vascularity. I believe we are going to touch the vascularity and the vascularization index and the flow index in the next part, but here this is a general scanning where we can take the size of the ovary, and the best way to take the size of the ovary, which is of course no, take a 3D, we'll take a vocal. So we are now going to demonstrate how we are going to do the most effective way of accurate assessment of the ovarian volume, because here the ovarian volumes play the key. If we are to follow the Rotterdam criteria, the Rotterdam criteria was saying more than 10 cc or even 12 cc. But then of course there have been certain studies after that where they say that it's not necessary that the ovary has to be 12 or more. We have to look at the morphology of the ovary also. So here we are now going to do the vocal, and here what I prefer generally is there are two ways on which we can do it, but I'll generally do it on the screen so that you people can see. What I'm going to do is I'm going to encircle the.
So he has traced it at one and then he'll trace it on the other, and he'll trace it three times, and then the machine will calculate the volume, automatic volume calculation for them. You see, we getting all the planes together on the picture, and then
this is 30 degrees jump, sir.
So 30 degrees you trace the ovary, again 30 degrees more.
So we'll have those 6. 13 to 6 is 180 complete.
So
we'll have the 6th one, and that will give us
6 times you do, so 180 degrees you've done, and then it will calculate the volume. There it is.
So it is now 11.6.
So it's just borderline. 12 is what we said.
12.
It was a PCO.
And then we can go into the inversion mode. Okay, threshold.
So
fine.
your threshold, you see the follicles, you color them differently.
Now, as far as threshold is concerned, this is another interesting area in which we've reduced the threshold now, and then we'll gradually increase it. See, look at the area of the pinks which are happening. Threshold volume will tell us the amount of volume of the cystic areas and the amount of volume of the solid areas in the ovary. Now, in what happens in PCODs?
You have Sono EVC also on this.
Okay, all right. So in that case, what will happen is,
okay, we'll show it in the next.
okay, what will happen is, now here we can see that 71% is the above threshold, which means that the solid areas in this ovary are more than the cystic areas. Normally it should be 50 to 60%, but this is slightly more, which means that the stroma is excess, and the stroma of course is more echogenic. So this is one important issue here, and then we can go back to the inversion mode, because we are going to show Sono AVC at a.
This antral follicular counting.
Yes, we are coming to that. Inversion mode karo. We can have intral follicular count here, and these days this machine is going to tell us.
So this machine tells you automatically a lot of things.
Sir,
makes life easier.
Sir, I would request
Uh-huh.
to show antral follicular count.
We'll just do that.
With
The audience wants to know
if-
which machine are you using?
If suppose we have
You're using the Volison V8. E8.
Dr. Prasad here wants to know
The Mercedes of ultrasound machines.
wants to show us the basic antral follicular count without using the 3Ds and 4Ds.
in a
So we are
Maruti
going to
car,
do that.
If you are driving a Maruti car, how will you do that?
So the Mercedes
that
does it
is,
itself,
let's.
but you want to see
let's
it in a
click on
Maruti
it.
car, then we count.
Okay, so this is how we'll do it. What we do is, once we focus the ovary, we look at the longest section of the ovary. So we can rotate the probe and see the longest section, and from one edge of the ovary, like so.
1,
we-
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, maybe 14, maybe 15.
So it is more than, and then couple of them here.
Couple
also,
of the
sir.
16, 17, 18.
So I
So
think it's around 18 to 20. sir.
anything above 12 is PCO. Anything less than 2 or 3 is poor responder, and you add both the ovaries and you get 5 is probably 5 to 10, 12 would be, you can say that ovary will respond. Now what he's
Right,
showing
sir.
you as a very beautiful thing is the stromal color. Now this stromal color will tell you whether this ovary will hyperstimulate or not stimulate.
Yes.
So if there is too much stromal color, and if he puts the Doppler there, he's doing it on power angio, and he puts the Doppler in and you see a big diastolic blood flow, all the drug, the gonadotropins which you are going to go, will go straight into the ovary and hyperstimulate this ovary. So, or if it is resistant, that means the resistant index is 8 or something, 9, 0.8 or 0.9, then the drug will not blow, and this PCO will be poor responder or a resistant PCO. So that is what color Doppler or ultrasound predicts in PCOS. So you got a wave pattern, and you look at the wave pattern, you see a systole and a diastole, and you see here the diastole is almost 40% of the systole. So the resistance around 0.6 in this. So this would be towards a hyper responder ovary than a poor responder. So you have to be very careful giving high doses of gonadotropins here, because this ovary will land into OHSS definitely.
So at what level
You see the resistance of 0.6 ke aspas. See 0.6, I told you just looking at the wave. So you have to see how much systole and how much diastole. And approximately you see 0.62, 0.72, all the radiologist friends will give, but for us, we are worried about 0.6, 0.7, I mean basics. And this, bas relax, bas 1 minute. Okay. So that's beautifully done, very nicely seen now. Similarly, we can go to the other ovary. I think the other ovary is stuck behind the uterus, and probably there is an adhesion there, which I saw when you was.
Now, if you allow me, sir,
Yeah.
let me do some vascularization index, or maybe we'll reserve it for the next session.
So
I'll just save it.
3D will tell you the vascularization index. That again, this machine, see, beautifully tells you how much vessels that ovary has.
But then we don't have time.
The newer
I think
values will
we-
come with
we manage.
VFI and vascularization index, which will be much more predictive than a normal. Hopefully, we are not very sure right now. The initial papers have started coming, so maybe yes, this would help much. But a vascularization index of the endometrium, but definitely is going to be much more helpful in predicting endometrial receptivity rather.
So this is the other ovary.
So that other ovary which I saw when he was scanning is stuck behind, and you
Yeah.
push and pull, and the whole uterus and ovary moves together. So that's probably an infective pathology which has occurred here, or endometriosis, because I'm thinking of adenomyosis. So probably she has endometriosis also along with it, or maybe a severe attack of PI. See, he's pushing and pulling, and both the ovary and uterus
the
moving
uterus
together.
Moving together.
Timortish push and pull sign.
So which means that this is adherent.
So this ovary is adherent. When you
What
do
has
an
been the clinical profile of this patient? Has this patient undergone a laparoscopy?
yeah, she's undergone a laparohysto, only bulky ovaries, rest everything normal is what was written. So again he's doing the sweep on the other ovary to see it's that volume. That also looks slightly polycystic. We are just saying the
Enlarged.
ovaries are polycystic. We are not saying she has
Enlarged.
polycystic ovarian disease. Because if she has polycystic ovarian disease, then the clinical and the endocrinological matchup should be there. 2 out of 3 Rotterdam criteria should be there.
So another nice way to see, rather than doing the live thing, is that we take a 3D sweep and we walk through the view. And here we can see the 2 follicles here. We can see 4 more. That makes it 6. This is 7, 8, 9, 10, 11, and then 12, 13, and 14, 15, 16. So there are more than 12 follicles in this ovary also.
So 16 plus 16, her antral follicle count is 32, which is a very high antral follicle count. So I would go ahead and do an AMH also to her, and she'd probably have an high AMH, and she's got more color flow, so she's going to be a hyper responder, and she's failed with IUIs. So the next step, and there is adhesion of the ovary. That ovary might be difficult for ovarian pickup also, because they're adherent to the fundus. The needle might not reach there. So we have to be careful. The ultrasound tells you that also, or guides you that. So if she goes for IVF and she has a small pathology, myometrial cyst,
Yes.
which we still have to make sure what it is. It could be infection, it could be endometriosis or adenomyosis, or it could be AV malformation. It's not AV malformations because no color.
No color.
So
So I still feel that with that adherent one ovary and
It
with
is
those
infective
cysts,
pathology.
I think it is quite infective.
it
Plus
is
maybe,
myometritis which has caused
which has
probably.
caused this problem. So I guess we need to run some investigations to rule out those infective pathologies. So I guess this is another session where we'll be showing you the colors and how to do the vascularization index of the endometrium. We will be doing the flow index in the ovarian stromas, and we'll be doing the uterine artery Dopplers.
Okay, I want to show them
And so therefore, am I finished
Yeah, I'm
yet, or is Dr. Malhotra taking the day 9? Day 9 he's taking. But can I then demonstrate
Either.
a uterine artery Doppler? Dr. Lele, can I demonstrate a uterine artery Doppler meanwhile if he's taking? All right. So we've got just about 1 minute in which I am going to demonstrate a uterine artery Doppler. Why do we do a uterine artery Doppler? Uterine artery Doppler is important in situations like PCOD because it is the male hormones, and the male hormones will cause
Carry on.
androgenic vasoconstriction, and so we know that the uterine artery PI values will rise, and So that's it. We can do half-half, or whatever that is. Okay. Yeah. So let's have a auto trace here. The auto trace would be, yeah. So we have a PI value of 2. So we know that in PCODs, if the uterine artery is giving us a PI value of around 3 or more, that could be associated with blastocyst failures, implantation failures, and recurrent abortions. So here in this case, the uterine arteries appear to be normal, at least on one side. Please remember, we must do the uterine arteries on both the sides. So therefore, this is a preliminary base day 2 scan, and we are going to come back for the Dopplers, the sono AVC, and the vascularities.
Thank you very much, Dr. Vivek. Now we'll be shifting to day 9 scan, which will be demonstrated by Dr. Narendra Malhotra.
Speak loudly, you're not audible in the auditorium.
Can you see us?
Yeah,
Thank you.
Yeah, can you see, and can you see the machine which we are using?
we can see the screen all right.
Hello?
Are we audible and are we visible?
Yeah,
Hello?
Yeah?
yes.
Here is a patient, 32 years old. She is married for last 14
Aarti,
years.
please speak into the mic, can't hear you.
Or pass.
She is 32 years old, married for 14 years. She had previous one IVF failed. She has her
Not
last
clear, absolutely.
Okay, she's 32 years, previous IVF failed, 14 years married and anxious to conceive. And now she has come on day 9 for us to evaluate what we can find wrong in her. Is that clear?
Absolutely, please go ahead.
Okay, so now we have this machine which we are using, E8, which is as we told you in both the rooms, which is the Mercedes of the ultrasound machines. And what I'm going to use is a condom, and what we do is put the jelly inside the condom rather than here. See, if I put jelly here and when I roll the condom, jelly is going to spill over the shaft. So we put it inside and we roll the condom over it. And because of this probe, this is a 3D probe, it just sticks there, so we don't have to tape it. So it's stuck nicely. And now we have to remember the beam is going to go like this. So this has to be anterior. And when this is anterior, if you look at the screen where E8 is written, that anterior will come here. So when the patient is lying down and we are putting the probe here, bladder, uterus and the pouch of Douglas. But you have to orient the image 90 degrees because the image is going to come like this. Ideally, I would be very happy if the image comes like this. Bladder, uterus and all. You can't do this. In some machines it was tried, but now you can't do it. Now because she is day 9, no IUI is planned, nothing. So we'll put some jelly outside and then we'll gently introduce the probe and we'll put it at the introitus first. So I have not introduced the probe, but the probe is just outside. And what do we see outside? A little bit of bladder, and this is the probe which is going, and the vagina is closed. So when we move in, the vagina opens because it's potentially, and because she's been lying for a longer time, we have a slightly full bladder. And as we are entering, we start seeing a solid organ behind, and then we'll orient our probe to get in line of what we're seeing. Finally, when we touch the anterior fornix or the anterior, we start seeing the cervix. And if it is anteverted, my hand goes up, anterior lip, posterior lip, the posterior fornix, the external os, the cervical canal, and then it turns here into the endometrium, and my hand goes down. I see the uterus in beautifully longitudinal view. So I've gone systematically vagina, cervix, uterus, endometrium, and then I will rotate by 90 degrees to get a coronal view or a transverse section. And when you see a transverse section, you on both sides you see some vessels. These are the uterine vessels, and the endometrium is 3 layer which we can see. Then we'll come back straight and go to one of the fornix. So right fornix, right ovary, 1, 2, 3, 4, and left side, left ovary, again 1, 2, 3. So small follicles which are measuring about 10 or 11, I think, approximately we'll measure and tell you. And there is some free fluid in the pouch of Douglas. Day 9, this free fluid is probably slightly PID, but if it was ovulatory on day 12 or something, then it could be an ovulatory fluid. And once you have free fluid, then maybe you can see the part of the tube fimbria also floating here. So you see the tube can be seen only if there is fluid outside or inside. So now people want to know whether what problem she has. So on apparent screening, she appears to be an absolutely normal day 9. And what Vivek was saying, we just saw a peristalsis here. So the peristalsis from day 10 onwards will be moving from the cervix up. So take the sperms, and from day of conception, when the blastocyst comes, the peristalsis go the other way. And during menstrual cycle also it rises from the cornua to the cervix. So that is how you can see peristalsis in the uterus. This ovary is lying in the pouch of Douglas. There is fluid, there is fimbria. Can you see the fimber-like? So there is no fimbrial adhesions. We zoom it. And we can zoom it and show you. So the fimbrial ovarian relationship also can be seen. Now I want to see the adhesion in pouch of Douglas. So I am going to push and pull. Push inside and pull. So the uterus slides over all the organs which are there. All these organs inside are either, this is all peritoneum and bowel, and this is ovary. So they slide, sliding organ. Everything is sliding. So there is no ovarian adhesion, there is no uterine adhesion. Right ovary, again we push and pull, so no adhesion. So we've ruled out that also. You see how beautifully you can see the sliding side. So apparently this is absolutely normal. It's a normal responding ovary, so she should respond to stimulation. And of course to reevaluate what has gone wrong, probably the endometrial receptive must have gone wrong. So we can look at the color, and we see that the color is still outer zone. And we can look at the uterine artery Doppler. That's a uterine artery, and and we can see whether the uterine artery is too. So uterine artery has got a high resistant flow. It is still not showing more diastolic. The more diastolic flow will come on day 12 or 13 if the ovulation goes on normally. So this is a normal uterine artery, and what I told you approximate, that is systole, this is diastole. So diastolic flow as compared to systolic flow is about 20%. So the resistance must be 0.8. And that is how we as clinicians should be doing it. The radiologist friend will give it you 0.84, 0.83, but I am interested in whether it is crossed or become more, that is up to 0.5 or half. Then I am very happy at putting in embryos or doing an IUI. Or if it remains like this at the time of ovulation, then I am not very happy with this flow. So that is how I would look at Dopplers without looking at absolute numbers, and by looking at the wave pattern.
The fluid in pouch of Douglas was minimal, correct?
Minimum. This is probably normal fluid and
So
maybe some PID.
We keep on reading
So this appears to be normal, and I think it should be taken at for
clinically rule out PID. I think it's quite a sweeping statement made most of the times. Dr. Naren, are you listening?
Yeah.
I said lots of time ultrasound reports come, fluid seen in pouch of Douglas,
PID.
please clinically correlate PID.
Yeah.
I think that is a very sweeping statement made.
You know, it is very difficult to actually diagnose PID just by looking at fluid. I don't think it should be made like that. So you have to look at probe tenderness, you look at other signs of infection, oophorytis or myometritis or endometritis, fluid in the endometrium. If all those are happening, then a pelvic inflammatory disease is happening. Or if there is particles in that fluid, then maybe it pus or something like that, or blood.
Like in
So
cardio,
a lot of things. A general sweeping statement is to keep your probably safeguard, and this is one of the diagnoses. You have to make a diagnosis, so you just write rule out PID. So PID is a clinical plus imaging diagnosis combined. You can't just say on ultrasound it's a PID, and you can't just say sometimes on. See, on PV, when we do, a gynecologist does a PV examination and you press on the cervix, patient does ouch, and you say PID, infection. So that was also a very sweep, and you start prescribing antibiotic. However, if there is tenderness and fluid, then you could give a trial of antibiotics and anti-inflammatory and rescan the patient after 7-8 days. And if you say if the symptoms relieve, then probably it was PID. That is how I go about it.
Right, thank you.
24 years old, married for 5 years. She is secondary infertility. She has previous one abortion at 3-month gestational age. Her endocrine profile within normal limits. Hysteroscopically she was okay, and viral markers were not detected. She has one IUI done in February, and now she has stimulated for the second one. On day 2, she has received clomiphene citrate. Day 2 to day 6, she has received clomiphene citrate 100 milligram once a day, and added with day 6 to day 8 HMG 75 international unit. On day 9 there was no response. On day 11 she has on left side she has only one follicle, 14 mm, and her endometrial thickness was 0.6 mm. Today is the day 13 scan for you. Thank you.
Okay, now this happens in clinical situation. First, let us see what she has, and then we'll discuss why this has happened.
Uterus. Let's have a nice setting for the uterus.
And what should we be doing now when this has happened?
So this is a nice trilaminar endometrium. There we getting it, and we can see that the vascularity. Let's take a look at the vascularity, and because the uterus is a little, I believe. Okay, vascularity we can see now. We can see now the vascularity and the nice endometrium, which is trilaminar. And if we can take the endometrial volume, volumes are more accurate than the thickness. But here, due to paucity of time, let us see if we have time. We'll do the endometrial volume. Otherwise, just to say that the gross endometrial thickness is 11 millimeters. Now we are looking at the patient's right. That is the left ovary, and that is the right ovary. So here we have very large bilateral ovaries with very large number of prominent follicles. The average size being, though it will be a good practice to measure at least the 5 largest follicles in each ovary and report them. But the point, so this is around 15 to 16 millimeters follicles, and it's always a good idea to turn on your power Dopplers and to see a perifollicular vascularities. Perifollicular vascularities, some literature says, are indicative of how good that egg is going to be, and you can select, especially so more for the IVFs, you can select those eggs which have got a good perifollicular vascularity. Here the vascularity around the follicles appears to be good. We can do a 3D sweep of this, and we can then, here we are doing the 3D sweeps, and we can get the perifollicular vascularities. Also we can calculate the flow index.
Dr. Kashyap, what was the day 2 scan of this patient?
Day 2 scan, antral follicle count.
She was a diagnosed case of PCO.
So she is a PCO case which did not respond till day 9.
Till then.
And then she has suddenly blown up into a full-blown OHSS now. So here we are seeing about 20 follicles each on both the ovaries, and day 2 had a PCO, but she did not respond till 9. Now what happens in PCOS, they have, or these follicles or anyone, they have a certain threshold of FSH level when the follicles start responding. So that threshold has to be met. So when she was given clomiphene, the clomiphene acted via the pituitary of the patient and secreted FSH. Now that FSH of the mother of the patient was not enough to stimulate the patient. So when we added HMG 75 only, on second day of adding the HMG injection, probably the threshold crossed and all of the follicles started growing. So the third injection was also given. So all of them have landed up into these many, about 20 or about 15 on both the sides, with good color and with a very good endometrium. Now ideally what should we be doing is a big question remains here.
Vocal.
Patient is stimulated, she is going to give you good eggs, but if you do IUI, she has a very high chances of having triplets, quadruplets or anything. So in my setting, I would cancel this case for IUI and convert her into IVF.
IVF, I guess.
But now it is too late. You can't, because her LH peak must have started, the pituitary must have started responding and giving an LH peak any time, maybe today, maybe tomorrow. So we cannot stun that LH peak. So if the LH peak of the patient comes herself, she is going to ovulate, and we'll all lose all that. So probably on day 9, when we saw on the first HMG injection, many follicles were coming, we could have started her on antagonist and kept her on antagonist till today. And when it is 16 or maybe tomorrow at 17, we could have given an HCG trigger. No, not HCG here, because she was on antagonist, so should be given an agonist trigger to prevent OHSS, and we should have done a follicle oocyte retrieval on 4th of May after giving it in 36 hours later, 5th May morning, and then frozen all the embryos. I would still be very scared of transferring embryos into her, because if she conceives, which she is likely to, because she has a very good endometrium, but then she'll land up into a more severe OHSS. So I'll freeze all these embryos and use them in the next cycle. Now why she would fail also with IVF is because of 20-30 follicles, her estradiol level would be very high. So very high supraphysiological estradiol is also detrimental for implantation. So she'll probably fail because for that reason also.
That will have an ill effect on the endometrial lining.
Obviously, though endometrium is growing right now very well, but so today what you want me to do? I'll do an estradiol level. If it is definitely going to be more than 3,000 or 4,000, and that warrants my cancellation. And we've lost the cycle for IVF. We cannot rescue her for IVF because she's probably at 16. At 16, giving an antagonist would not work. So she'll definitely ovulate the bigger ones. So she's cancelled for me.
Would you like to do an ovum pickup in this case?
No, for what? We can't give her HCG. She has already started her LH peak. If you give HCG right now, then I don't know. You'll get 3 or 4 out of 20, but maybe you can try that. But I would have loved to put her on antagonist 2 days back and then given HCG today and did an ovum pickup 36 hours later after today. So tonight and 4th morning, that would have been, had she been given antagonist on 29th and 30th. That would have, and today. But she's not been given antagonist, so her pituitary is already secreting LH. If you do her LH level, they'll already be there. So if you give an HCG today, just now, that peak will come 36 hours. But her follicles will start rupturing from tonight. So we'll lose more than 60% of the follicles because of her endogenous LH peak, which is already triggered, as according to me. We can do an LH urine test and see whether that peak is coming or not. It can easily be done. Or you can, if that is not available, a simple pregnancy test HCG will also tell you that the LH peak is coming, because cross reacts with the in those tests. So this case is non-rescuable, unless you want to go ahead and do an IUI and risk a triplet or a quadruplet.
I think frozen embryos is another.
We can't take her now. Antagonist diya hi nahi hai. So if you put
There is a
HCG,
lady who has shown
Right.
pictures of OHSS
So Dr. Malhotra is going to show us.
HMG.
Dr. Malhotra is going to show us another case, but for the crossover, we've got just about 30 seconds in which I would like to show you the flow index here.
कदों आया महीना?
We have done a vocal and we've done on
IVF
part
का injection लग रहा है?
and we've got a
कितने
histogram
लग रहे
done, and this
5 लग गए? Good.
We can't hear you. Kindly speak into the mic, please.
IVF stimulated follicular monitor.
I hope we have as many as those. in her, इसमें 2 उसमें 15. नहीं दिखाते हैं, कम poor responder भी दिखाएंगे ना. You can always, hello आओ जी, क्या हाल? Lovely, perfect stimulation. बिल्कुल.
पास हो गए सर.
This is what is wanted. Not that.
पास हो गए.
आ जाओ.
This crosstalk
अब सोनल दिखाएगी, उसके
is
बाद
not
हम
letting
बोलेंगे.
you-
हम लोग नीचे जाके बोलेंगे. नहीं. चलो लाओ. मैं तो अभी पी ली. I just had green tea.
Dr. Kashyap, could you repeat what you were going to tell us? There was a crosstalk coming in.
Yeah,
well,
because-
okay.
See,
Hello.
look there and speak. Look in the camera and speak.
Narendra, if you switch off your mic, we can hear all what you're telling us.
Yeah. Yeah, green tea.
Okay, in that case, hello.
Okay, we've come to this room.
Hello.
She is 36.
Hello.
She is 36 years old. She
Hello, can you
is,
hear me, please?
Married for last 10 years.
Acha.
And she has...
Toss a coin and decide who's gonna speak.
married for 10 years. She has regular menstrual cycle. Her hysteroscopy, laparoscopy is within normal limits, and endocrine profile is within normal limits. She has been taken for long protocol IVF, and injection Lupride was started at day 21 with 1 ml subcutaneously, and at day 2 she has started with recombinant FSH, and today is her day 8.
So day 8, IVF stimulated case. We should know what we want. We want a good endometrium and we want some good
Naren, please
follicles.
put on your mic, we cannot hear you.
Hello. This mic on? Ye mic.
Yeah,
Can
clear.
you hear me now?
Yeah, better.
Okay, so day 8 of IVF stimulation with recombinant FSH in a 36-year-old. So she is on the higher side of age. So I'm expecting, or I would love to see some 5 follicles on each side, measuring about 12, 13 at this, or maybe even 10 would do good for me, and a good endometrium. So if we don't see a good endometrium, we change our protocol. If we don't see good follicles, we increase our dose here. And if we see everything is going on, we carry on with the IVF protocol. So again, we have do systemic scanning. So we go and look at the uterus first, the cervix. Now beautiful cervix. This is an infertility specialist dream cervix, and this is a mid-cycle cervix. The external os is open. There is a lot of cervical mucus. The anterior lip, the posterior lip, some mucus is trickling into the vagina also. So this, if I look at this picture at a mid-cycle, I would say her hypothalamic, pituitary, ovarian, endometrial, cervical axis is normal. So for me, this is a good window for the endocrine of the patient. So she probably has a very good estradiol which has acted on the cervical gland. So estradiol has definitely crossed 200 when the cervical glands start responding and produce mucus. So definitely there is going to be a good endometrium without even looking at the endometrium. So let's come to the endometrium. Hola, there it is, beautiful endometrium. And you see what we look at, we see the layers. We see the texture, we see the hypoechoic area around, so those vessels, and we see a homogeneous myometrium all around, and that's the internal os. So perfect, lovely endometrium, and probably measuring around 8 or 9. We can do an exact measure. I go to the right side, 1, 2, 3, 4, 5, 6. 6 equal sized follicles without a lot of stroma, a beautifully well stimulated ovary, an ideal stimulation for an IVF, which we want. We are looking in IVF cycle to get 9 to 10 eggs out of a woman, not 20 to 30, because 20 to 30 puts her life at risk with OHSS. So this is an ideal stimulated ovary, and we can measure that. We can measure the arrow here. So I'll just measure just to tell you. Okay. We try to get it as spherical as possible, and
Beautiful, very nice coordination. I'm so impressed.
and get one reading. So 12.6, that is what I expected. I told you at day 8 I'm looking for a follicle at 12 to 13. They're all same, so I'm not measuring all of them and wasting my time for academic. The other ovary, 1, 2, 3, 4. Again lovely. So 6 and 4, 10. Ideal IVF stimulation at 36. You couldn't have asked for better. So good stimulation, good endometrium, good estradiol as the cervical mucus tells you. She is going on the right track, same dose to be maintained, and of course as soon as it reaches 17 or 18, whatever your protocol is, you give HCG and do a oocyte pickup at 36 hours. That is how we will go.
They want to know what is the dose of FSH you have given.
I think no, they're giving 75 or what? No, they're giving 200 Folisurge. 200.
They want to see the vascularity of the endometrium as well as
Vascularity, okay. So vascularity of the endometrium, I would be more looking at the vascularity of the endometrium if it was poor, or when it was the time of embryo transfer. Here you will see the vascularity on the two zone outer and zone 1 or zone 2, and beautifully you can see in power Doppler the vessels are going into zone 2. By day 12-13 the vascularity will go here. Beautiful vascularity.
Thank you, Dr. Malhotra. Now we will be shifting to our next patient, which is an frozen embryo transfer, and the endometrial preparation is being done for her.
There's a query from the audience. What are the settings you use for the color flow?
See, these are preset according to you just sit with one of the patient, preset according to what gives you the best. Otherwise it is a high filter. I mean the settings, can you show the settings of the color? So PRF, Dr. Sonal will tell you the exact settings what will get you the best.
The PRF has to be 0.3 and the wall filter at the lowest for your color and power, and for
Where's
your
the tissue?
spectral
Tissue.
Doppler PRF at 1.3 and wall filter at low 1. That should be the settings in the G, Wallison, E8 or E10.
Later.
We have to put in.
Can't hear you, please.
Basically, your PRF should be set in such a way that the minimum flow velocity recordable should be at least 2 to 3 centimeters per second.
Thank you.
See, what does she mean by when the mother's heart pumps blood, the blood flows into the artery like that, and it flows with a velocity. So that velocity, the more the organ demands, more the velocity, and more the organ is muscular, more pulse. It will go up as systole in the systole, and when the mother's heart rests in diastole, the muscular part of the artery contracts and still pushes blood. About 30% of the blood should go forward still in diastole at a certain velocity. And if it is going slowly, as it does in spiral arteries, 2 to 3 centimeters per second, then you have to put it on power Doppler and you have to get the settings right to pick up that slow velocity, low velocity. High velocity blood flow will be picked up at anything. And if you get aliasing, then you have to reduce the PRF. Increase the PRF. So you have to increase, and that's the PRF is the pulse repetitive frequency. So the pulse is coming from the Doppler beam is coming, it is hitting the RBCs, coming back and calculating the velocity or giving you a waveform. So it tells you the velocity, it tells you the pulsatility of that vessel, how much pulsatility, and it tells you the resistance. If the resistance to the blood flow is less, the diastolic will be more. So it will be half of the systole wave. If it is very muscular, then the pulsatility will be high, and if it is very low velocity, then you just see that the velocity which it gives you on the site will not be the peak systolic velocity. That's how we calculate.
Thank you.
So now we are moving on to the next case, and
Hello. She is 27-year-old female, married for 9 years. She had scanty menses and prolonged cycle. She had previous 2 IVF done. First was failed and second one has 1 cryoloop preserved. ET was not done because during stimulation she had polyp. So ET was postponed, and now she once in next cycle when she has started with Progonova, she was not responding. She is a poor responder. She has been given 2 milligram of Progonova for 10 days, and HMG was added for HMG 75 international unit was added in previous 4 days, and she has received sildenafil and for the last 3 days, and GCMF was put on day 7. Now her ET, what you can see.
well, see here we have a case which was stimulated, and I find the endometrium.
For 10 days. That's what.
So I find the endometrium at around 6 millimeters, which is rather disappointing. And here what we are also going to look at is using a 3D of the uterus. We can maybe make out a little contour. The fundal contour is a little depressed here. It could be a case of arcuate uterus here, and because can you see this? This should be actually a nice triangular area here, like the one we did earlier. And if you want, we can show you what a normal one would look like. A normal one would be a triangular one like so. And here what we are looking at in this case is, so here we can see a nice triangular, but here in this case what we saw was a little arcuate uterus. Oops, I did not do I did not save that volume. So I'm going to take that volume. It's only going to take about 1 minute, and we are also going to do the endometrial volume. But please remember, the incidental finding here is that possibly she's got arcuate uterus. And arcuate uterus, yeah, we'll see the vascularity. But the one thing that has been registered now is that she's possibly a case of arcuate uterus, like so. So here we can process.
Actually see the cornu also very beautifully if you want to show that.
Yeah, and we have the two ostia and the cornu, like so. This is one, and that is the other one, and we can. I basically had put in this volume because I wanted to show you the endometrial volume. So we can do a vocal on this, and so a vocal would start vocal on 30 degrees. That is how we are going to start the vocal. Vocal is going to give us the endometrial volume, and we know very well that apart from the endometrial thickness, the endometrial volume is also very, very important, because endometrial volume of about 3 is a very good one, and endometrial volume less than 1, according to some studies, shows that the it's nil.
What is the significance of the endometrial volume?
So the endometrial volume is actually a better indicator and a far more accurate assessment of the endometrial mass or the endometrial tissue, rather than just measuring the thickness, because endometrial volume is going to be so this endometrium is just about 1 cc. So 1 cc.
There are actually a lot of studies here which say that if the endometrial volume is less than 2 ml, in this case, no matter how much is the thickness, the receptivity of the endometrium is extremely poor.
Extremely poor.
And so therefore, this is specially applied when there is either a persistently thin endometrium, but if the uterus otherwise is long, it will suffice for the volume. Oh, you cannot hear me, or you cannot?
No, nothing. Whatever you have said, we have not heard.
Okay. Hello.
Yeah.
Is that okay?
Yeah.
Yeah, there are a lot of studies, in fact, which say that if the endometrial volume is less than 2 ml, the receptivity of the endometrium is extremely low as compared to when it is more than 2 ml. And therefore, I mean, this is specially applied clinically in all those cases where it's persistently thin endometrium. But if the uterus is long, the total volume goes to about 2 ml, and you can still do a transfer. But if the endometrium is thick, but the uterus is short, the volume is less than 2 ml, and then the transfers, the receptivity of the endometrium is extremely poor. So that's how the thickness is given less importance than the volume these days.
Now, when we talk about vascularity?
Yeah, you have to. Dr. Vivek will probably talk on the vascularity. He has already put the Dopplers on.
Yeah.
Yes, we are taking the vascularity of the endometrium, and we take a nice volume. Make sure that there's no artifacts, and the color settings need to be good. I'm doing it in a rather okay. So there we do a volume analysis, and then vocal at 30 degrees, and so we start taking the.
You usually measure the volume up to the internal os.
This is where it's going, right? Because these settings actually for all machines are a little different, so we need to get familiar with the machines. It's important. And So we are going to take these so-called 6 traces at 30 degrees each. That makes it 180. This is a little artifact, but we should have, in our normal clinical practice, we should take it again. But here, because of the time constraints, we are proceeding with this. Maybe there'll be some not very accurate, but then just to get an idea of how and what is the importance of this, we are tracing the endometrium, and this is accept and volume histogram. So here we have a flow index of 28 and the VI of 15.
You can also use a glass body rendering if you like for that.
Yeah, glass body rendering we can do. कहाँ पर गया?
Render mode, yeah.
No, not the wire mesh.
No glass body, there.
So you see
So
with the
even-
glass body, you see it white, and then you see the blood vessels.
So even if you don't remember the numbers, it tells you about the
vascular it is.
vascularity of the endometrium.
And we can just rotate it.
And you can rotate it. And
Oh,
put it on ceiling. So that's it.
Yeah, we are storing it. So I think after tracing this endometrium, again it's confirming us that possibly this is a case of a little arcuate variety.
Yeah.
That's
From
okay.
poor
It doesn't
endometrium, we
affect
are
the
going to
fertility
good
that much.
endometrium.
I think arcuate is more hyped, overhyped than
Now
usual.
another patient for FET. We have 31 years old.
Talk it loud.
She is married for 7 years. First IVF was done, and during after picking
Pardon?
up, endometrium has fluid in the cavity.
One, very poor.
And she has been planned for FET.
I
Day
want to
2,
see hopefully ma'am,
Progonova was started.
Hycosi
And
today.
today is
Let's see. We are
on
lucky.
day 10 scan. She has thin endometrium, and today is day 18 scan.
18
Continued.
scan and on Progynova, and we would
than
Now
usual.
another patient for FET. We have 31 years
Talk it
old.
loud.
She is married for 7 years. First IVF was done, and during after picking
Pardon?
up, endometrium has fluid in the cavity.
One, very poor.
And she has been planned for FET.
I
Day
want to
2,
see hopefully ma'am,
Progonova was started.
Hycosi
And
today.
today is
Let's see. We are
on
lucky.
day 10 scan. She has thin endometrium, and today is day 18 scan.
18
Continued.
scan and on Progynova, and we would embryo transfer. Then we're definitely going to look at something more than 7 and a good 3 layer with good blood flows. So if this is a retroverted uterus, and when I do it transversely, I see probably it is an arcuate uterus also. So that is why probably she is not responding. Here you see that's the main endometrial cavity, and probably here there's a small septum and the smaller type of cavity, or maybe there is an adhesion there. So we will just see with transverse scan here. Do a 3D on this. So we'll just take a 3D scan just to see the cavity, whether it's convex, concave. And we just did a color flow before on this. The color blood flow is quite good, and the thickest part, the endometrium, is reaching 6-9. So which is just at the borderline for doing an FET. So one more day of Progynova and we can try that. Cavity ठीक है. So cavity is what was appearing as one side. You see, still the one side is more healthier, and this side is a little bit. But the grossly the cavity appears normal. So, and when we measure the thickest part here from outer
6465. So one place I had measured 69, so it's just at the borderline of FET. We don't do frozen embryo transfers if it is less than 6, but at 6 to 7 we decide on the quality of embryos, and of course above 7 we will take any, and then of course we will put the power Doppler on to see for the blood flow. So the blood flow is quite good and reaching zone 4 also, and of course you can do the volumes and you can do the flow index to exactly predict your implantation. Now this is at a borderline of endometrial receptivity. I won't say the endometrial receptivity is absolutely ideal and very good, but or very poor. It's at the borderline. So your decision for doing an embryo transfer frozen in her would depend on clinical. Maybe 1 more or 2 more days of estradiol, and then if she does not remains like this, maybe you can cancel and do it next time and add next time you add sildenafil, arginine, aspirin, even low molecular weight heparin, or if you want to do, maybe we could put in granulocyte stimulating factor right today and tomorrow, and it will definitely improve day after. So we could do a GCS injection today and look again tomorrow, maybe do it tomorrow again and do the ET day after. So we could do that.
Married female, 20 years old, and she is married for last 5 years. She has previous one abortion, and she has bilateral tubal block, and ovarian drill has been done during laparoscopy. She is resistant PCO with us, and she is on stimulation day 13. Total dose of FSH she has received more than 2,000 international unit.
So we have introduced the probe already inside. Dr. Malhotra has beautifully shown you how to follow the vagina. I just wanted to point out one thing, and that is because we already have a panel discussion on endometriosis today evening, and we are going to look at, we are going to evaluate ultrasound. I would just want to specify here that we need to see the tissue interfaces between the vagina and the urethra, and between the rectum and the vagina. When we are introducing the probe, there we are into the vagina, touching the cervix. We are seeing the whole long axis of the cervix, of the uterus, moving from one side to the other side, rotating the probe 90 degree for the transverse section, going towards the fundus down, and we can beautifully see the arcuate uterine cavity. You can see the concavity there. So we are going back up and then towards one of the ovaries. We'll take the 3 of the uterus a little later. We are going towards one of the ovaries. When we go to the ovaries, of course, this is a very evident and a clear case of a PCO. We have clear hyperechoic stroma. The stromal echogenicity is always compared to the echogenicity of the myometrium. So the way you do is you freeze the myometrium there on one frame, and on the other frame you look at the stroma of the ovary, and then you compare the echogenicity of the stroma to the myometrium. That tells you it's a hyperechoic stroma. Going to the sono AVC, why we have, for which we have done this scan actually is, because it's a PCO ovary, we can either count the number of follicles as we earlier did by eyeballing, but we know these are too many, so we will just switch on a 3D, set our box, the 3D box, large enough to include the whole of the ovary, try to rotate the probe and find out the best section of the ovary, preferably the longest one, and then we will increase the gain a little to make the margins in between the follicles clear there, and we acquire a section, acquire a volume of the ovary, that is the complete volume of the ovary. No, because you can not see the part of the ovary on the B section. That means we need a little larger angle of acquisition, and the angle of acquisition is seen over here. I'm going to increase the angle of acquisition a little, but I believe that is, yeah, that is the maximum I can. I have increased it a little by 10 degree or so, and then I'm again acquiring it. Unless the whole ovary is included in the volume, the number of follicles that we count are going to be still not okay, so I need to rotate it and take another section so that that volume angle would be enough. It's actually a huge ovary, but I'll not waste much more time there. I would. And we will directly switch over to Sono AVC. There are two ways you can do Sono AVCs. There are some machines wherein you need to do a vocal and then apply Sono AVC, and there are some machines where you can switch over directly to Sono AVC without doing a vocal for it. And here in this case we can do it directly. So I've just put my box large enough to include the whole ovary, and now what Sono AVC does is, it based on the echogenicity, it differentiates between the fluid filled structures and the solid structures, and that's what it has done. You can see here there are a lot of follicles that it has counted, but it has also counted this as a follicle, which is actually a vessel. We have on Sono AVC a post processing menu wherein we can cut, merge, or even add or remove the follicles which are not included or vessels which are included. So I'm going to remove this vessel here. I just have to press there. That goes away. With that, the complete line, complete cohort, 1, 2, 3, probably 4 follicles have also gone away. So I'll again select that, and then I can cut them into individual follicles as that. And I believe there's one more here, and the 4th one is here. So I've outlined them, they are all cut, and now I can remove the rest of the part which was actually the vessel. So that's how you can do it, and then you keep on walking through one of the images that you select and keep on adding the follicles which the machine has not counted. Yeah, we will do it. Yeah. So this is also additional, I believe. Yeah, but there is a small follicle still there remaining, so I want to include that actually. So what I'll do is I'll again outline this, and then I'll remove the rest. I believe that's okay. And then you're moving one by one, just from one plane to the other. See if you have left any follicles. Even smaller follicles can be counted if you want to. And that's off. Back.
For our gynecologist friends here, Sono AVC is a automated volume calculation.
That's right.
And it gives you a very good view of all the follicles in 3D.
See, its advantages, number one, it color codes the follicle. Because it color codes the follicles, that means it's not going to overcount. Because you can do a post processing, anything that is left, you can count it. Anything which has been measured as a large one, you can cut it. And moreover, one function which I have not shown you is that if at all required, you can merge also 2 follicles. I know this is not a single follicle, but just to show you the function, you can even merge these 2 follicles, right? So it makes a single follicle. So that's how it gives you the complete, not only the number of follicles, the size of follicles in the form of the report. Size of follicles in the form of X, Y and Z diameters. As you can see here, you can see the mean diameter and the volume. So that's an excellent assessment of the follicle on Sono AVC. Because it's a resistant PCO, I want to show you one thing, and that is the stromal vascularity as was being discussed in the earlier session. Sono AVC, the vascularity, the response of the ovary is decided on based on the stromal vascularity, and if the stromal RI is high and the PSP is low, these are the cases where you would require to stimulate this patient with higher doses in spite of her high antral follicle count. It is probably because, okay, now this is a very good flow, but that is after 13 days of stimulation. So this is a post-stimulated, but if you would have seen this on a baseline scan, it would have definitely been a lower flow, and that is why this patient, in spite of showing so many follicles, is a poor resistant patient. Just 1 minute for that uterus. You can render it. Or the easier way or a time saving way is to go to the multiplanners and just use a VCI on the C, and that would give you a nice arcuate uterus. Yeah?
Yeah, very nicely visible.
Yeah, so we are done with that patient and we are shifting over to the next one.
She is the lady, she was told on HSG, she has biconduit uterus. When we put the laparoscope, we couldn't answer anything because uterus was engulfed in the adhesion. So we have to take the help of 3D, 4D scan. Now she is ready.
Hi everyone. Now this is a very interesting case, and this is just to demonstrate the role of ultrasound as a problem solving tool. As you heard the lady, the hysteroscope was inconclusive. There was a suspicion of a biconduit uterus, but still we are not sure whether this is biconduit or this is septate. So we are going to demonstrate now how we can use 3D ultrasound as a problem solving tool. So this is a nice section of the uterus. This is a nice longitudinal view. But before we go on to 3D, if you can just see on the transverse view, can you see two endometrial echoes?
Yes, nicely.
So we have two endometrial echoes which are nicely visible, and they are separated by a myometrial tissue in between. On a longitudinal section, if we say end-to-end sweeps, we see that there's one nice endometrial echo here. Moving towards the center, we see the disappearance of the endometrial echoes, and crossing over to the other side, we see again another endometrial echo appearing. So which means that we are possibly dealing with a biconduit uterus. But please remember, the differentiation between biconduit uterus and septate uterus is extremely important. Why? Because as clinicians you know very well that septate uterus is generally a treatable cause in possibly OPD as an OPD procedure. So what we are doing is we are taking a 3D sweep now of this uterus, and so we are waiting. Please remember that the volume angle is now 151, which is quite a large one, and the slower the acquisition, the better the resolution, because that the machine is going to take. Now what I am going to do is I am going to do an omni view. Omni view is yes, now we can have a trace, and omni view is the simplest method in which you simply trace a line across the endometrium like so and like so. So there you go, and if we do that, we can, yeah, VCI, and then we can take those, this one, what was that? Yeah, no, we can rotate it on that degrees. It's a little, yeah, okay. So there now we can see the uterus, which is, can we increase the angle of the VCI? Can we increase this angle? Yeah. So let's see, if we increase the angle, we are able to pick up the two cornu. We are going to take another acquisition, and It's very important to change the settings for every patient because every patient is different. In this case, what was happening was that possibly the settings now we've changed, and hopefully we should get a very, very good view, and we should be able to differentiate between a septate uterus and a biconjugate one. So there we go, and can we get the foreview please? And then yeah, go on to B plane, and then we can change it, make it wider on the B plane, and then come back and try and see if we can manipulate it. Yes. So are you able to see now? Are you able to see now?
Yes.
So we are going to see the two cornu, one on this side and the other one on this side. And this is widely separated cornu, and we can even do the HD live, and we can yeah, edit the light. Edit it please. No, can we do it on the on from the ball? Yeah, from the ball. Yes. So we are now able to see that this is actually a biconjugate uterus where the two cornu are widely separated from each other, like so. This is one cornu and this is the other cornu. Although the endometrium and the myometrial interface appears to be good, but this is one piece of tissue that I am a little curious about. I want to know what is this. So then I'll save this image and I'll further go through walk-through view. This is, I'll go through the multiplanar views and try to see what we have here. So we can go back to sepia. Can we go back to sepia please? Yeah, and we can change the settings and we can see that. Okay, now it's important to differentiate a biconjugate from a septate. How? These are 2 points. Can we measure there are two surfaces of a uterus. One is a fundal surface, another is a serosal surface. Now what happens is that if there's an indentation in the fundal surface which is more than 1 centimeter and the serosal surface does not have an indentation, it's likely to be septate. However, if the serosal surface also has an indentation and the fundal surface also has an indentation, it's likely to be biconjugate. Please remember, biconjugate will have a serosal indentation. So we have to identify not only the fundus, the picture does not end here. We have to look at the serosal surface, and serosal surface would be higher up. So here we will try to
Bishop, do you think putting power flow is going to help us in making the differentiation?
We will definitely do the vascularity after this. First, we are going to identify the fundal surface and the serosal surface. Once we have identified that this is a biconjugate uterus, then we will do the power Doppler, and or else if it's a septate uterus, we'll definitely do a power Doppler and we'll check out the vascularity of the septum, because that is going to affect the chances of any fertility in this patient.
Here we are not seeing the septal depression. Are you right? I mean the fundal serosal depression. Dr. Kashyap?
Yes, we are working on it.
For us, from looking at here, it looks more like a septum.
More like a septum, yeah.
So it's a wide septum, what it looks like.
See, the differentiation is that if it is more than 60 degree separation, and of course MRI has got different criteria, but to follow that on ultrasound, although there's no set studies still that what is the degree of the separation of the two cornu, but so to say that if it is 60 degrees or more, it is likely to be biconjugate. However, we are trying to identify the serosal surface here, and if we are able to see the serosal surface, we have to actually spend some time in trying to identify the serosa, and if that is happening, then we know for sure that it is a biconjugate and not a, sometimes the trick lies in.
See, we can see the septate here.
Yeah, so possibly there's a serosal indentation, but we can save it for the, I'm saving it and we can work on it, and we are also now going to do a power Doppler here. And let us see, maybe power Doppler gives us more information. So then here, oops, okay, no, I wanted an A only, and A was change. I wanted, no, I want this on A.
So why we
Yeah.
want to look at the color is if it is septum, then and when we go to cut, probably it's going to bleed. So we must know, that's how it will make the surgeon aware of the color
Also the implantation rates.
and implantations on.
They say that the more the vascular the septum is, higher the chances of an abortion. Because of the high vascularity, the septum tends to have more peristalsis. Some studies have even pointed out on that.
Or it will implant on the septum.
Or in the uterine endocavity, somewhere near the septum, the vascularity should be less.
Kashyap, can you take a transfer section and take the sweep? That becomes much more easier, I think. Yeah, now take yes.
See, looking at this black and white picture, it definitely looks like a septum, 2D picture. So take the sweep at this side. If the fundus is single, no indentation of the serous layer. It's a wide septum. It's a very thick septum.
Thick, short septum.
Now the question would be to cut or not to cut. See, now this
now
picture
you
is
can see
this.
that one.
Now you can see how wide it is, a wide septum. So because it's very wide, that's why it confuses with biconvex. But
So do you look at the width or look at the length of the septum?
Both.
Or whether it will go for
Both.
We look at both, ma'am.
both, and the angle which it forms. If you join the cornea, then it will form an angle.
There are two ways to.
In fact, we can measure
differentiate
this,
between
measure
a
line.
and a biconvex. One is to draw a line, intercorneal line, and see whether it is cutting the fundus or not. That is one. Two is the acute angle or the obtuse angle which it subtends with the fundal surface of the cavity. So these are the two ways by which you can. Here we have a very thick subseptate uterus.
So the idea is to take the indentation. We know that it is 8 millimeters indentation, which is less than what we would generally find in a biconvex uterus. Also, we need to measure both the cornu so that we can put it in our reports and give a correct picture to the clinicians so that they can plan their further course of action. So most likely the serosa appears to be intact, and also another so the serosa appears to be intact. Plus, if you can see the little cystic area, this is what was showing in our 3D images also. This is in between the two.
So what next we can do is, if someone there is willing to do it, just slide in a feeding tube inside the cervix and connect it with sterile saline and push saline while he is scanning.
Yeah, saline infusion.
And it is
Yeah,
saline
we can do
infusion
that.
sonography. You can just do it right now and show us. It'll be beautiful, and then take a 3D.
I don't know if
If someone can do that. Someone,
Yeah, of course
I think
we are
there
ready.
A couple of gynecologists this time.
Yeah, we can do that. Saline
It
infusion color.
just needs a feeding tube, infant feeding tube, or a number 8.
Sir,
He'll
we
go
are-
in.
So we are doing it. In the meanwhile, we'll shift on the other side.
Yeah, you shift on the other side till that you can put here.
Here is a patient, 37 years old, female, married for 15 years. She is case of secondary infertility. She has previous 2 abortions and no menstrual irregularity. Her LMP is
That's okay.
9th of April.
That's
Day 21 scan now for you.
So probe in the vagina, and you can see it's a retroverted uterus because the external os is anteriorly towards the bladder, and we are tracing the cervix down.
Acutely antiflex.
Yeah, that's an acutely antiflexed uterus, and
Antiflexed over a retrovirgin. This is the
that's
worst uterus.
it's not even acutely, but it's antiflexed. Yeah, that's true, and you can clearly see that the myometrium is very, very thick. Not only that, there is a clear ear-shaped endometrial cavity. Ear-lobe-shaped endometrial cavity, which is one of the important signs of adenomyosis. Looking at the myometrium again, you can see multiple hypoechoic areas, and multiple hyperechoic spots also, which are the bleeds inside. You can see break in the endomyo junction there, which is quite clear here, but it's broken here. It's being penetrated by the endometrial strands extending into the myometrium. And then if you go, so that means if it's a retroverted uterus, this is the posterior wall, this is the anterior wall, and on the anterior wall you are seeing another lesion, a focal lesion right here, which is clear hypoechoic. So on B mode it is adenomyosis and it might be an associated fibroid. And if you put on the Dopplers, adenomyosis we know has a penetrating vascularity, and you can see a lot of penetrating vascularity there in the adenomyotic myometrium. So that's very, very typical. This area here, which this area here, which actually looked like a localized lesion. Another localized lesion is not a fibroid because it shows penetrating vascularity as compared to the peripheral vascularity which you expect in a fibroid. Though here you cannot see, it's very far from the probe, and therefore the color pickup is extremely low over there. But still, you do not see any penetrating vascularity there. Yeah, so it tells you that's a fibroid.
Classic salt and pepper appearance of the virus.
Yeah, that's right.
Just now when we were having a break, we labeled it as cut Dhokla sign.
Yeah, and
you see those cystic spaces.
And if you do a 3D of that, this is specifically why I am doing it. If I don't do anything, if I just use it as it renders, does it look like a unicornate? But it is not. It looks like that because it is a very acutely anteverted and also a slightly rotated uterus. You have to, in this cases, confirm that it is not a unicornate only by either rotating the rendered image, or you can go for a VCI, where we need a little increased contrast on that. And that is where you can beautifully see both the cornu. Can you identify both the cornu here? So it's not a unicornate. So this is one lesson. I mean, it's an important message that even if you on the first rendering see it looks like, if the uterus looks like unicornate, unless you have rotated it 380 degree or 360 degree, or you have done it, look at the coronal section with an omni view, you should not say it is an unicornate. And the indication was here on the transverse section, which clearly shows both cornu. Yes?
Yes.
Yeah.
Okay.
Moreover, this is a secretory scan just to show you a nice corpus luteum there, and the corpus luteum, remember, always has an excellent flow, and it's a low resistance excellent flow, which you can see there, right? So it's a nice corpus luteal flow, and in spite of that good corpus luteum, the endometrial vascularity can be low because of adenomyosis. And it is in this case that you may also look at the uterine artery going on to the lateral aspect and increasing the PRF a little, and that shows you the uterine artery. Thank you. We shift over back to the bicornuate course.
Just because
She
the
is 25 years old girl, married for only 5 months. She has history of menorrhagia only for 5 months. Previous cycle were very regular. Now she is with you.
okay, well, thank you. Now in this case, what we are looking at, once we let me just do it from the start. So here this is on a transvaginal scanning. We see a rather globular uterus with a mass lesion sitting right within the endometrial echoes. Now, which means with a posterior acoustic shadows. Now, which means that we are dealing with a mass lesion arising from or around the endometrium. So the first thing I would like to do is put on color and like to see what is the vascularity of this lesion. So here we see that this lesion per se is avascular. Having done that, we are going to do a 3D sweep of this uterus and we are going to see what we are going to get. Now the probable diagnosis here would be a large fibroid which is submucoid and which is distorting the endometrium, and this is creating a problem for her. The other thing would have been a large polyp in the endometrium, but the kind of acoustic shadowing that we are looking at is unlikely to be due to polyp. Another, of course, is a growth, and so rather than so here we are now trying to. So the point is that, can you see this central point here on plane A, the corresponding on plane B and on C? So once we do that, and let us have a walkthrough view. Yes, so it's fairly distorting the endometrium, and this is involving the entire myometrium starting from the submucoid region to the serosal surface. So this is a large fibroid.
So nicely it is seen now delineated.
Which is submucoid to serosal. So it's very important for us to describe not only the size of the fibroid, but whether it is touching and distorting the endometrium and it is reaching up to the serosa. Another possibilities, of course, was adenomyosis. Here the vascularity is it's rather avascular, so it's unlikely to be adenomyosis. Plus, of course, then we need to see the characterization. But here what is curious is that her endometrium is not only thickened, but it's absolutely heterogeneous. There's no homogeneity in her endometrium, which is quite prominent. And in this case, this is as thick as 22 millimeters. And so possibly there
are two fibroids, or is it just one of them?
No.
This is one submucous and one intramural which is touching the serosa.
What I feel is that the lesion within the endometrium is different. Now I'm trying to put on the color Doppler and to see for any
one submucous which is in the
to see for any vascular stalks. This to rule out any polyps, a large polyp with a fibroid, or two fibroids. One is submucoid and the other is submucoid to subserous, and so therefore that is
the challenge in managing this.
Yeah, that is the challenge.
Now, the other information which we can gather by doing this 3D acquisition is that we can assess whether they can be hysteroscopically resected, depending on the amount of encroachment into the cavity, about the remaining myometrial thickness. Based on that, the resection possibility by hysteroscopic resection can also be assessed.
So this myoma is actually extending the entire width of the myometrium, and it is distorting the endometrium.
Yeah.
Therefore, to triage this patient onto, I think, an intervention would be a good idea, and I believe that maybe some endometrial biopsy could also be a good idea in this case. Possibly because of the heterogeneous endometrium.
No, because
I would
we
rather
do a hysteroscopic.
Yes.
Start with a hysteroscopic removal.
Yeah, that will cover that also.
See, if we cut laparoscopically, if you do laparoscopy first with the subserosa, then you won't be able to remove what is inside the cavity.
Yes.
So you start with hysteroscopy and remove as much as you can, and the whole thing just keeps on pushing. And there are chances that the whole thing might come out hysteroscopically only without cutting laparoscopy. So you've saved her a stitch on this. If it doesn't, then we abandon if it takes too much time and do a 2-stage hysteroscopic resection. So maybe after 2 months do it again. If not, if the internal is separate lesion, then we remove hysteroscopically and then tackle the subserosal laparoscopy.
Right. Meanwhile, we scanned her ovaries, which appear to be normal.
So when descent is there, then it makes it more interesting.
Yes.
Descent is only one. That before we embark on hysteroscopy for this patient, it is absolutely imperative to make sure that there is a sufficient amount of myometrium lying over the myoma. Because in case the myometrium is touching the serosa and we embark on a hysteroscopic procedure, we may be leaving behind a gaping hole. So in case the acoustic shadowing is not allowing us to clearly delineate the fibroid, in that case we may do an MRI and get a very clear idea that there is a sufficient amount of myometrium, and we will be able
increase
to do
the gain
a
here,
hysteroscopic
TGC.
resection. Because if there is a covering myometrium lying there, and as you start resecting the myoma, the intramyometrial part of the myoma automatically starts coming towards the cavity and it keeps coming up. So I just thought that, sir, against your great wisdom, this is Dr. Bhupesh Goel.
I think we've increased the
Actually,
gains.
this is where the role of MRI comes in, because when you have a multiple fibroids more than 5, that is 1. 2, when the volume of the uterus is more than 375 ml, that is the time when you need to do a MRI in order to know the exact location of the fibroids, the feasibility of hysteroscopy, and particularly when we have acoustic shadowing like this where we are not very sure about the serosa, it's always wise to get an MRI done before we even think of any resection.
Right.
But here he is showing that the
And even
fibroid is extending up to the serosal
No,
layer.
we are not
So
sure
there is-
because there is a caustic shadowing. We are not very sure still.
No. We have. Where's the volume? अच्छा ओके इनका ओवरीज का मैं स्कैन कर देता हूँ
हेलो हेलो हेलो
नहीं आ रहा है आपका तो आ रहा है इसमें हाँ वही तो गाने वाने शुरू हो गए
हेलो
अब नाच गाना माइक ऑन है
Can I be heard that side? Hello.
Yeah, we can hear you.
So thank you very much. I'd like to end the session here and thank Dr. Vivek, Dr. Sonal and Dr. Malhotra. It was definitely an enlightening session and I'm sure we all will be able to use all this knowledge in our day-to-day practice. I'll take you back to auditorium and hand over the mic to Major Venus.
This is a septuplet pregnancy which has been induced with HMG, and she has got the 6 pregnancies after an IUI. So we have already reduced 2 of them at around 11 weeks. We will further reduce 2 more to make it a twin pregnancy. So we have got a septuplet pregnancy. Now the issue is that before we start a reduction, I will not go to the intricacies at the moment. I'll show you the picture of the septuplet pregnancy, because before you start a reduction, we should map the pregnancies so that you do not damage the ones you are going to conserve. So we will map these pregnancies. I will go from the lower part of the uterine cavity and go upwards. You can see the 2 pregnancies at the moment. The 2 pregnancies, then you go ahead, another 3, another 2 come up here, and finally 2 more in the fundus. The top 2 ones have been reduced. You cannot see a cardiac activity there. If I'll just focus on there's no cardiac activity in this embryo. The other one on the other side, there's no cardiac activity. On the topmost pregnancy, if you can see, there's no cardiac activity. The lower one has got a cardiac activity. Put the color. You can see the cardiac activity in this embryo. Put the color off. Put the color on. There is no cardiac activity on the pregnancy next to the one which had the cardiac activity, which has been reduced earlier. So what I intend doing is, I will not reduce the pregnancies which is next to the cervix, because if you reduce those and if they start aborting, They will take all.
Arora, how many weeks pregnancy is this?
This is 12 weeks pregnancy. I prefer to do all the embryo reductions between 11 and 14 weeks.
You are not audible.
Hello.
Arora.
Hello. Am I audible now?
Yeah.
Sir, you can give it to her. She can hold it in front of me. I tend to reduce all these pregnancies. Hello. No, this is working. Around 12, between 11 and 14 weeks, because I've been practicing abdominal reductions since long. So I have, and I prefer to do it abdominally. So, hello, it's going up. Hello. Hello. Can you hear me now? Yes. Hello. So we'll reduce this. Put some. Tell me when I start. When to start. Hello.
Hello. मेरा sound आ रहा है, ma'am?
Only when you turn to our side is where we can hear you. When we go back to looking at the screen, the link is broken.
It's okay now? Hello.
We can't hear.
Hello.
Hello. Hello.
Hello.
Ma'am, can you hear us now?
No, it's not audible. Yeah, you just.
Hello. Yeah. So this is a 12-week pregnancy, and we have been introducing it between 11 and 14 weeks, because whatever auto reduction has to take place, it takes place by that time, and then we can assess the nuchal translucency between 11 and 14 weeks, and then we reduce the one which is got the maximum NTs. So the one which I have focused on, can see the heartbeat of this patient, of this embryo at the moment. Show the color, put the color. The heartbeat is now visible?
Yes, yes.
Okay. So what I now, after I have selected an embryo, you see the needle path I have already chosen, which will not interfere in any other of the sacs, and it is focused on the cardiac activity of the embryo. That particular embryo I am going to reduce, which is on the screen. Firstly I give a local anesthetic to the patient.
Could you have someone focus on the abdomen also?
Pate.
Wait.
Yeah, thank you.
Okay.
Yes.
So Seema, you come this side, because you have to inject KCL. So I'll ask my assistant to inject KCL moment I have inside the cardiac chamber of the embryo. So now with a freehand technique, we generally pierce the maternal abdomen. You can see the needle tip.
Yeah. Local anesthesia is what he said.
Yeah. So now the needle tip is just above the embryonic cardiac activity.
Okay.
But the embryo has changed the position now. This is the difficulty which we face repeatedly at times.
Dr. Ahuja, have you used any anesthetic or analgesic to reduce the fetal movement before you do this?
No, we have not used.
Okay.
We generally don't use because the pregnancy is in the first trimester, so generally avoid using.
Right.
Now to relocate my needle and focus to the.
the fetal thorax.
No, I have not pierced. Needle is here. You can see. I have not pierced the uterus as yet because I want the baby to be stable firstly, and then we will go ahead. Put some jelly. Betadine.
Is this a quadruplet pregnancy or a pentuplet?
It is a septuplet.
Sextuplet.
Okay. The needle tip is just near the sac. I'm going to pierce the sac now. I'm just waiting that I get an appropriate position of the baby, of the embryo rather. No, it is moved, baby has moved, embryo has moved now. You have to be careful when you're jabbing, so you should not go across the boards because you can damage the other sac also.
Right. Would the plane of the needle be better seen with a 3D scan?
No.
It's right, because it seems like it's going in and then it's probably by the side of the fetal thorax.
You see, the needle is in the cardiac chamber. You know, inject KCL. Yeah, remove the stellate. Just put 0.1 ml the KCL. Just, you can see that, don't push, Seema. You can see, push. Yeah, you can see that KCL going inside the cardiac chamber and distributing all over the fetal embryonic body. And the cardiac activity has stopped. Isn't it? Put the color. Put the color. Show. So there is no cardiac activity now. Okay. Okay. Color off. I am taking out the needle.
How much have you injected funnel earlier?
0.1 ml. Out.
Can you show us the needle also, which needle is used?
This is the needle. I have been using this it's an Italian needle which is available with this, and it's around the gauge is 15 centimeters long. So I have been doing fetal transfusion with the same needle also. It's a quite sharp and steady.
Are the needles reusable? The audience wants to know.
No, we don't reuse these needles for fetal intervention. So this is the one which I reduced. You see this actually before the screen was not shown. I was actually mapping the pregnancy earlier. You can see that the two of them. Put jelly here. So these are two pregnancies, the lower pole of the cervix, and then this another one here. Two here, one here, three, and then three more. So these are the earlier pregnancies which I have reduced. Just show the color. This one. So one. Then go below. Go, this is a living embryo. Come down. This is a living embryo. It's not clear. Increase again. Yeah. So these two are the living embryos here. So now she is left with 3 living embryos at the moment. So when you have a high order pregnancy, we tend to reduce over a period of 2 weeks, because if you give a embryonic reduction at one time and you make them 4 of them go at a particular moment, it causes a lot of release of cytokines and a lot of dead tissues available inside the uterine cavity, which actually initiates the process of abortion. So we go gradually, reduce 2 at one time, or maybe 1 at one time, and then give a couple of days time for that to resolve, and then redo the procedure subsequently. So the idea is, why I do abdominal route is that it's a more surer way of you can have ensured asepsis, and you are sure what is the NT of that particular embryo. And as I show you in the next case, a quadruplet pregnancy was transferred to me from Chandi Mandir, and she was referred to me at 9 weeks, and subsequently we waited till 11 weeks. One of them auto reduced. Now she's got a triplet. So we wait for auto reduction, so that it's a nature's way of selecting. The abnormal embryos should go by themselves, so that if you reduce them earlier, you may be that reduce the normal one, and the faulty one which is there may get reduced subsequently, causing loss of all the pregnancies. So I prefer to do it between 11 and 14 weeks. So this is I'll just demonstrate one embryo reduction in this. I'll go to the next patient. Okay. So we hold on, we'll go to the other one.
Patient is under, so we are going for the pickup for 2 minutes.
Okay, sir. Okay.
Yeah, just wanted to ask you that besides selecting the most accessible
No, ऐसे ये नीचे आना, दबा.
into consideration.
Yeah, now turn. Yeah, you can go ahead. Right.
Yes, sure. Because in the pre-op assessment, you are taking we are following 3 criteria for selection of the embryo which has to be reduced. One is the crown rump length. The second is the nuchal translucency, and of course the fetal viability. And in first trimester, at between 11 and 14 weeks, you can pick up a lot of abnormalities also, like cephaloceles, gross hydrocephalosis, anencephalus. So even you can have cystic hygromas can be picked up. So you reduce those ones which are abnormal. So crown rump length is one of those criteria which we follow. So this pregnancy is there with us for quite some time. So we know which one has to be reduced. We already mapped them, and we generally tend not to reduce the lower ones if the embryos are healthy, because they may initiate process of abortion. Because when the lower ones gets resolving, they may start spotting, and then they can induce abortion for the other babies also.
Would you also consider zygosity in determining which ones are to be reduced?
Yeah, good question. Zygosity, I personally feel that if you have got a monoamniotic sacs, so the chances of abnormalities are more in the monoamniotic ones. So we tend to reduce the one which is a monoamniotic.